essentially, RP1 is a novel innate agonist, an oncolytic virus that is encoding the cancer targeting protein GM-CSF in a novel attenuated herpes simplex virus that has got a Galvi strain that enhances immunogenicity. And what RP1 does is when it's injected within the tumor, it essentially directs tumor cells to die, brings in T cells that kills tumor cells, and also, very importantly, propagates an immune response. And the idea behind ARTACUS is, behind RP1 is that it's designed to have both a local and distant effects. Now, in the context of RP1 is being studied in many different cancers, including cutaneous squamous cell carcinoma. In the SURPASS study that has already been finished, the data has already been presented, and there are some discussions about whether or not this would be a regulatory study. There's certainly some data in advanced PD-1 relapse or refractory melanoma. The data is also pretty exciting, and further discussions are ongoing about the development of this agent in that space. But when we were thinking about ARTACUS, when we were thinking about RP1, we were thinking about where can we study RP1 as a single agent. What might be the unmet need which allows us to give these patients a drug like this? And so as we thought about that, we converged upon a unique indication that is transplant-associated skin cancer. Now, as it turns out, when you have a solid organ transplant, patients with a solid organ transplant have a higher likelihood of cancer. Well, a higher likelihood is not a doubling of risk or tripling of risk or an increase of risk by tenfold. It's a 100-fold increase in the risk of skin cancers. And the primary reason for that is the immunosuppression that is used to maintain allograft tolerance and prevent allograft rejection. And the use of immunosuppression such as tacrolimus, serolimus, mycophenolate, these agents which subvert the immune response to ideally prevent rejection, also reduce the ability of immune cells, T cells, to conduct effective immunosurveillance and prevents the ability of T cells to nip early stages of cancer, resulting in a much higher incidence of cancer, particularly in the Caucasian population, cutaneous squamous cell carcinoma, and other cutaneous malignancies. ARTACUS was designed as a trial in which we wanted to explore RP1 as a single agent. So why a single agent? Well, as it turns out, in the context of cutaneous tumors in patients with transplants, the use of a checkpoint inhibitor is relatively or absolutely contraindicated. Now, certainly, there's some provocative recent data by Dr. Glenn Hanna and Dr. Evan Lipson from Dana-Farber and Johns Hopkins, respectively, suggesting that you can modulate immunosuppression to allow for safe use of immune checkpoint blockade. And this is certainly a very interesting idea. However, we have to consider that while the strategy might be safe in patients with renal carcinomas, patients with chronic kidney disease who've had a renal allograft, the likelihood of being able to do this in patients with a cardiac allograft or a liver allograft or a pancreatic and a small bowel allograft may be more concerning because there is no backup plan if the heart, the liver, or the small bowel were to fail. Whereas if a patient had a kidney allograft that happened to fail, one could always put the patient back on dialysis. And so therefore, the patient population with solid organ transplants and concurrent cutaneous malignancies represents a huge a patient population with a huge unmet need in which the disease is both common, prevalent, and for which there's no standard treatment. And in this patient population, ARTACUS was designed to study the efficacy of RP1 monotherapy. And what we have observed is rather startlingly, one, that RP1 appears to be effective. There appears to be certainly no evidence of safety signals that are seen. There's no unwanted side effects. There do not appear to be unusual issues with herpes seroconversion. Even though these patients are technically immunosuppressed. So very importantly, the drug is safe with a very effective safety profile and no evidence of hepatic seroconversion. But most importantly, there's evidence of efficacy. The efficacy appears to be durable. We're seeing approximately 25-30% response rate in patients who are otherwise unable to get immune therapy. And in a subset of these patients, responses appear to be durable. These patients are receiving treatment. And certainly there have been patients who've actually completed a year of treatment and have stopped. So this data is very, very, very exciting. There's very huge interest on the part of many different stakeholders to try to explore the use of this drug. The stakeholders include oncologists, transplant physicians who are taking care of cardiac, renal, liver allografts, and also high-risk dermatologists for whom normally the treatment that they would offer would be surgery or more surgery. And all of these different stakeholders are now recognizing that potentially we now have a drug that we can offer our patients that is both safe and potentially efficacious. And so we welcome the further study of this drug in this space to try to see if we can potentially confirm the efficacy and see if we can offer our patients who have this otherwise huge unmet need a possible and promising treatment.